commences clinical periodontology in the 10th edition, and clinical periodontology in Paradise 5th edition has given the definition of halitosis as unpleasant odor of the expired air, whether the origin may be oral, malodor, specifically refers to such odor originating from the oral cavity itself. And moving on to halitosis, the definition given by AAP glossary, oral odor that is unpleasant or offensive to others, caused by a variety of factors including periodontal disease, xerostomia, bacterial or fungal coating of tongue or dental processes, systemic disorders like diabetes, upper respiratory infections, different types of food, and use of tobacco products, also known as Fetex exor, Fetor oris, and stomatodysodia, and commonly referred to as bad. Moving on to the classification, halitosis is classified into main three branches, which is pseudohalitosis or genuine halitosis and temporary halitosis. And genuine halitosis is subdivided into physiological halitosis and pathological halitosis. Physiological halitosis is mainly caused due to tongue coating, and pathological halitosis is caused mainly either due to periodontal factors or others. Periodontal factors include ANAC, or your periodontitis, and other factors include xerostomia and caries. And genuine halitosis, which is, as we saw earlier, it is divided into physiological and pathological. Physiological is mainly due to morning breath odor, tobacco smoking, and certain foods and medications. And pathological halitosis include intraoral or extraoral origin. 90% of patients, it arises from oral cavity, bacteria, volatile compounds, and the pseudohalitosis includes apparently healthy individuals, and halitophobia is a condition where exaggerated fear of having halitosis is there, and also referred to as delusional halitosis, concerning variant of monosymptomatic hypochondrial psychosis or egg-bomb. And coming on to etiology, intraoral origin, it is 80 to 90 percentage, and due to oral hygiene carries periodontal disease, in particular necrotizing ulcerative gingivitis and periodontitis, and pericornitis, dry socket, other oral infections, tongue coating, and oral carcinomas. Extraoral origin is mainly the cause is only 10 to 20 percentage, and it is due to GI diseases, infections or malignancies in respiratory tract, chronic sinusitis and tonsillitis, and stomach, intestine, liver, or kidney affected by systemic disease. And these are the common causes of halitosis. First, we can see the local causes, including food impaction, acute gingivitis, aggressive periodontitis, pericornitis, dry sockets, xerostomia, oral ulcerations, and oral maladies. And respiratory diseases include sinusitis, tonsillitis, malignancies, and bronchiectasis. And your volatile foodstuffs include garlic, onion, and spices. And coming to systemic causes, it might be due to acute febrile illness, leukemia, respiratory tract infections, Helicobacter pylori infections, which is a H. pylori infections, pharyngoesophageal diverticulum, gastroesophageal reflux disease, pyrolic stenosis or duodenal obstruction, hepatic failure, renal failure, diabetic ketoacidosis, trimethylaminoria, hypermethylaminoemia, and menstruation. Examples of systemic pathological conditions with their characteristic order include you can see acetone or sweet fruity odor in diabetes mellitus patients, urine or ammonia, you can have adrenal failure, flesh cadaver smell will be there for liver failure patients, and foul and putrefactive smell is present in tuberculosis or lung abscess, and decomposed blood smell will be there in internal hemorrhage and blood disorders. Order due to xerostomia and poor oral hygiene will be fever and role of volatile sulfur compounds in the pathogenesis of halitosis. Major compounds implicated in halitosis are your volatile sulfur compounds, which consist of methyl mercaptan, hydrogen sulfide, dimethyl sulfide, and dimethyl disulfide. Polyamides include putrescine, cadaverine, scatol, indole. And short-chain fatty acids involving include butyric, propionic, valeric, and isovaleric acid. Others include acetone, acetaldehyde, ethanol. It increases the permeability of oral mucosa and clavicular epithelium. It impairs oxygen utilization by host cells and reacts with cellular proteins and interferes with collagen maturation. It increases the secretion of collagenases, prostaglandins from fibroblasts, which in turn increases the collagen solubility. So this volatile sulfur complex also reduces the intracellular pH, inhibits cell growth, and periodontal cell migration, and it decreases the DNA synthesis. So what they're trying to say is the VSCs, which is your volatile sulfur compounds, along with reducing your bad odor, which is your halitosis, it also leads to increases in the collagen stability, and also it reduces the intercellular pH and inhibits cell growth and periodontal cell migration. And coming to pathogens of malodor, first it is mainly caused due to diet, with addition to bacteria and addition to epithelial cells, which is converted into get carried over to peptides and proteins, carried over to amino acids, break down to putrefaction products, and break and given to the clinical fracture of oral. And some drugs that cause halitosis includes tobacco, alcohol, chloral hydrate, nitrites and nitrates, dimethyl sulfoxide, disulfiram, cytotoxic agents, phenothiazines, and amphetamine. Coming to diagnosis of halitosis, it can be done by self-assessment test, which is subjective test that is subjected to one individual person. There can be whole mouth odor, which is cupped breath. The subjects are instructed to smell the odor emanating from their entire mouth by cupping their hands over their mouth and breathing through the nose. The presence or absence of malodor can be evaluated by patient himself or herself. Then wrist lick test, which is subjects are asked to extend their tongue and lick their wrist in perpendicular fashion. The presence of odor is judged by smelling the wrist after 5 seconds at a distance of about 3 centimeters. Moving on to spoon test, which is a plastic spoon is used to scrape and scoop material from back region of the tongue. The odor is judged by smelling the spoon after 5 seconds at a distance of about 5 centimeters organoleptically. Moving on to dental floss test, unwaxed floss is passed through interproximal contacts and it is. And coming to objective test, that is, it is not just subjected to a single individual person, a clinician, or the patient. It is a very confirmatory test. So, objective test includes organoleptic measurement, gas chromatography, your sulfide monitoring, electronic nose, your Bana test, your tongue coating test, your dark field or phase contrast microscopy, and saliva incubation. So organoleptic measurements or sniff test includes organoleptic measurement is a sensory test scored on the basis of examiner's perceptions of a subject oral malodor. Organoleptic measurements can be carried out simply by sniffing the patient's breath and scoring the level of oral malodor. So this is how organoleptic test is carried. And organoleptic scores are given into 0 to 5, where 0 is absence of halitosis, 1 is questionable halitosis, 2 is slight halitosis, 3 is given for moderate halitosis, 4 is given for strong halitosis, and 5 is given for severe halitosis. The volatile sulfide monitor, this electronic halometer analyzes concentration of hydrogen sulfide and methyl mercaptan, but without discriminating with. And your gas chromatography performed with apparatus equipped with flame photometric detector is specific for detecting sulfur in mouth air. It measures directly the three volatile sulfur compounds, methyl mercaptan, hydrogen sulfide, and dimethyl sulfide. Gas chromatography is considered the gold standard for measuring oral malodor. The device can analyze air, saliva, clavicular fluids, or a volatile component. So this is how the device looks like. And coming to a Halitox system, it is quick and simple. It detects both volatile sulfur compounds and polyamines in the sample. The absorbent point given with the kit is inserted into the pocket, left in place for 1 minute. Submerge the absorbent point tip in the toxin reagent, wait for 5 minutes and see for yellow color in the specimen on the scale of 0 to 3, which is directly proportional to the level of toxins. So this is how the Halitox system. Coming to your electronic nose, which is given by Tanaka M. et al., used as electronic nose to clinically assess oral malodor and examine the association between oral malodor strength and oral health status. Coming to the most important test, which is your Bana test, used to determine the proteolytic activity of certain oral anaerobes, which is causing your halitosis or which is producing the volatile sulfur compounds that contribute to your oral malodor. The test works on the principle that certain periopathogenic bacteria have the capability to reduce N-benzol DL-arginine B-naphthalamide, which is shortly termed as Bana, which can be detected using a chassis. So next, moving on to dark field or phase contrast microscopy, gingivitis and periodontitis are typically associated with a higher incidence of motile organism and spirochetes, so shifts in these proportions allow monitoring of therapeutic progress. Another advantage of direct microscopy is that the patient becomes aware of bacteria being present in the plaque, tongue coating, and saliva, so that they consider that oral hygiene maintenance will be better. Moving to preventive measures rather than curative aspects are highly recommended. Go visit your dentist regularly, periodical tooth cleaning by dental professionals, brushing of teeth twice daily with appropriate brushing techniques after a duration of 2 to 3 minutes, use of a tongue scraper to get rid of lurking odor causing bacteria and surface. Flossing after brushing to remove food particles stuck in between the tooth surface, limit intake of strong odor spices, limit sugar and caffeine intake, drink plenty of water, chew sugars-free gums for a minute with mouth feels dry, eat fresh, fibrous vegetables such as carrots. And these are the classification of halitosis of corresponding to treatment needs. The genuine halitosis will have a treatment one, which is to protect active outer with the oral cavity. Origin is mainly posterior region of the tongue. So this is mainly due to temporary halitosis, like eating garlic. And coming to pathological halitosis, it can be oral or extraoral. So oral requires, it is mainly due to disease and pathological conditions or malfunction of oral tissues and given by tongue coating. Where extraoral will be due to nasal, your pulmonary tract, your upper digestive tract, and originates from any disorders anywhere else in the body, like bloodborne and emitted via lungs. So next comes your pseudohalitosis, which is come as under treatment 1 and 4, which will be requiring first you have to clear dentist and oral hygiene has to be followed, and explanation of examined data has to be taken well with all proper restrictions and education and reassurance. And your halitophobia, which requires first explanation of halitosis and instruction of oral hygiene, and then referral to a clinical psychologist, psychiatrist, or other psychological specialist. Coming to a management of oral malodor, mechanical reduction of intraoral nutrients and microorganisms, chemical reduction of oral microbial load, rendering malodorous gases more volatile, masking the malodor, use of effluent. So mechanical reduction is by tongue cleaning, toothbrush, dental cleaning, professional preventive chewing gum. The chemical reduction includes all these methods like extreme dioxide, essential oils, mouthwash, dry cloth, mouthwash, and your conversion of volatile sulfur compounds by using this sugar-free chewing gums toothpaste. And masking the malodor by rinses and mouth sprays and lozenges containing volatiles. So coming to conclusion,